Hello, good morning to you all. I'm Sofía Grille. For those of you who don't know me, I'm from Uruguay, and it's a pleasure for me to introduce this satellite symposium organized by Novartis. In this symposium, we will deal with very interesting things, which is
respuesta inmune en los síndromes mielodisplásicos y cómo se puede modular terapéuticamente este microambiente medular que sería futuro.
Microenvironment. This is an additional therapeutical option for our patients, and it is an honor for me to present Dr. Boada from hematology in Uruguay. She's a hematologist. She's a bioscience patient. She's carrying out a PhD where she studies all of these topics. She's an assistant of the Policlínicas Hospital. So, Matilde, the floor is yours so that you start your presentation. Well, good morning. This presentation will be about the microenvironment and inflammasome. The MDS are a heterogeneous group of clonal hemopathies where there's one or more lines. This is a consequence of an inefficient hematopoiesis characterized by the increased death of progenitors and stem cells and a clonal proliferation of them. Through time, the classification of MDS has been evolving, and now we have the classification of WHO of 2016, which identifies these 8 entities. Within the MDS, there are different groups regarding their risk of progression to AML and regarding survival also. So we will have low risk and high risk MDS. The low risk MDS, which are cataloged by international agencies like the IPSS and the RIPSS. These categories are subgroups in low and high risk. The low risk will clinically present as cytopenias with evolution during years, and actually they are different from high risk, since high risk will have deeper cytopenias, blast excess most of the times at the beginning or later with a higher risk of progressing to AML. But apart from these clinical differences, there are differences in the pathogenesis and in the basis of this disease. Low-risk MDS will be characterized by presenting an expansion and proliferation of common progenitors. This is the population that expands in low-risk MDS, and there's an increased cell death in these common myeloid progenitors. And the high-risk MDS has a proliferation and an expansion of more differentiated granulocytic and monocytic progenitors. And in general, these progenitors show this progression which favors the progression towards AML. Why are there differences between the low and high-risk pathogenesis? This could be explained by the differences in genetic and epigenetic alterations in both groups of diseases. The epigenetics and genetic alterations in low risk has to do with initiating alterations, when a higher risk it will be related to AML progression. However, it seems to be clear that with these differences in genetic and epigenetic, it won't be enough to explain why the pathogenesis is so different, that the role of the microenvironment within this process of disease has a lot of relevance. Why are we speaking about niche or microenvironment? Because the bone marrow is not a tissue which is formed by hematopoietic progenitor cells. There is an important component which is the microenvironment. The medullary microenvironment is a very important part of the medullary tissue made up by different cells. Mesenchymal component, which will be mature, like osteoblasts, adipocytes, among others, but also by more immature elements like mesenchymal stromal cells, which is a pluripotential, and it plays a role in generating other mature mesenchymal elements and differentiating from them. It will play a role in keeping hematopoiesis and at the bone marrow level. There are other cells like the immune system effector cells, and we will find mature like T cells, macrophages, which will play a role in the immunoregulating function. So this microenvironment, is it a starting or facilitating agent? This is key in the selection and in the promotion of these two different populations. In 2010, the Rushmaker group published this in Nature, where in a very good model, they determined that the modification of stromal components of a bone progenitor is capable of inducing a dysplastic phenotype. They prove it by evidencing that the mice having an alteration at the stroma level developed dysplastic hematopoiesis with peripheral cytopenias, and this, if they were infused progenitors from mice without the alteration but had this altered stroma, the dysplastic phenomena repeated itself, while those progenitors coming from this mouse with this stromal alteration, infusing this in a wild type, the hematopoiesis was restored then. So, in reality, this work is very important in determining the role of the stroma. This is not the only work, and subsequently there were multiple studies in the area with different animal models which proved this theory as well. But this has also a counterpart in human beings, which is the Schramm-Diamond syndrome, where there's congenital failure with a more predisposition to developing MDS. In Schramm-Diamond, the mutation of SBDS will be the homologous of DISOR1, which is a protein that is altered in Rushmaker's mice. There's evidence to support a potential initiating role of the strome, but there's evidence to support the facilitating role because we know that the myelodysplastic role modifies these to favor this pathological hematopoiesis, and then we have a dysfunctional microenvironment promoting the progression of disease. And this is what makes us speak about disease from the tissue. This is not exclusively hematopoietic, and it has the hematopoietic component. What happens in the microenvironment? Considering the components that we have, there are mesenchymal niche cells that have an important role to play. In the process of disease, in myelodysplasias, there's evidence of significant differences between mesenchymal cells of the patients and normal patients as well. And all of this leads to an activation of a more pro-inflammatory profile of mesenchymal and stromal cells, and how this pro-inflammatory profile develops a deregulated inflammation response towards pro-inflammation, and how this acts on the hematopoietic component, generating the stimulation of pathogenic clones with more oxidation, with more inflammation, favoring new mutations so that this dysfunction will perpetuate itself. But it also favors the selection of pathogenic progenitors and favoring disease. So the mesenchymal component of the stroma, as we said, participate in this immune regulation. But the relationship of MDS and the immune response is known for a long time, because since the 90s, the patients had higher incidence of anemia, a lot of incidence of autoimmune pathologies, particularly have a greater risk of having autoimmune pathology. And all of this supported with the fact that some MDS, like the hypoplastic, respond very well to immunosuppressive agents and immunomodulating agents. In the pathogenic basis of MDSs, there's an imbalance between myelopoiesis and lipopoiesis with a bias towards lymphopoiesis. We have this, which is favored by different factors, mainly the microenvironment. We have the aging, which we know is very important when it comes to acquiring genetic and epigenetic changes, but also a chronic inflammation. As we said, it will play a very important role both as a starting and as a facilitating of agent for this process and autoimmunity phenomena. All the elements of the modular microenvironment, both in the mesenchymal support and in the immune system, are capable and are necessary to keep the hematopoiesis and to keep these immunosurveillance. But it is when they are dysfunctional, they can act harming or generating mechanisms that will support progression of disease. There's also around an imbalance between the pro-inflammatory cytokines with MDS. This has been widely known. Many people worked on this correlation not only between patients and controls, but within the patients, the levels were correlated in parananin with the prognosis of disease, regardless of the other prognostic factors. But lately, the fact that the cytokine profiles will be differentiated depending on the risk group. Low group patients will have higher levels of IL-6, 8, and TNF, while high risk will have higher levels of IL-10 and TGF-beta. What happens in the bone marrow with MDS, of low-risk MDS, is that there's a pro-inflammatory response. The pro-inflammatory prevails, and actually what happens is that there's a production of inflammatory cytokines leading to apoptosis, peroptosis. This drops the production of differentiating cells, and this in turn generates like a feedback loop with a pro-inflammatory environment where new mutations are acquired, and all of this favors the evolution of disease. This first step of low-risk MDS has a lot of inflammation, mutations, epigenetic changes, increased apoptosis, and recruitment of suppressing myeloid cells that will keep on feeding this cell, but also this cycle, but they will also produce immunosuppressing cytokines, and they will be the link between the low risk and high risk disease, because this is actually a continuum. And these immunosuppressing cytokines produced by myeloid suppressing cells would add and promote this immunosuppressing environment where the proliferation and progression to AML will prevail. So now, considering this immune response, many elements of the innate immunity are key in how this affects the hematopoiesis, because the stem cells express receptors of the toll-like receptors, and they will be the link to endogenous and exogenous links, which could be showing patterns of harm of the host, like PAMPs and DAMPs. They will receive external signals and they will adapt the hematopoiesis to what's going on, because this is not something static. It is capable to adapting to the different conditions, and in this adaptation, it might produce more differentiated elements or might be able to block certain lines. So in MDS, There's a role of toll-like receptors at the stem cell progenitor level, and it will be expressed differently. There are some intracellular expression. They will act through multiple intermediaries, and it could be TLR, TLR4, TLR2, and this will stimulate some certain genes that have to do with other mechanisms as well. But in reality, the toll-like receptor activation will be increased in MDS because there are more receptors and subtypes expressed more. And this stimulation by way of these receptors will favor the maturation towards the monocyte macrophage line, and the lymphopoiesis will be less regulated. The activation of toll-like receptors will activate the inflammasome, and in this way it will speed up the apoptosis. There's multiple trials which are valuing the evolution of the toll-like receptor action as a target on MDS, and Jorge will discuss this later on. Regarding what we said, that cell death of stem cells is a very important characteristic of MDS, especially low risk, we know that there are different mechanisms. At a time, we believe that the apoptosis was the first mechanism involved in cell death in MDS, but actually then we saw that pyroptosis, which is another way of cell death induced by inflammation, has a very important role, and when tissue samples are studied, this is a main death mechanism which is at play in this pathogenic situation, especially low-risk MDS. It activated through caspase 1, stimulated by toll-like receptors, and this death is a very important link, or has a very important link with inflammation, because it ends up determining the death of stem cells, progenitor cells. So the inflammasome is activated because of the toll-like receptor stimulation, like DAMPs, PAMPs, the alarmines, but also because of the activation of the myeloid progenitors as well. This is another way of activating the inflammasome with pro-inflammatory toxins which are released by the cells themselves. And in turn, the toll-like receptors and their stimulation will act through these pathways, and they will produce more pro-inflammatory signals. There is something else here, the myeloid suppressing cells that will be stimulated by the alarmins. By these mechanisms, so they produce more alarmins and feeding back this positive feedback, but also they will be starting producing immunosuppressive cytokines that will start recruiting the T-regulating lymphocytes, which will favor this towards a high-risk MDS. So this is like a paradigm of innate immunity. There's a deletion of the long arm of chromosome 5. It has a direct implication because in this sector there are important genes in the regulation of the immune response. The haploinsufficient generated by this lesion is related to the loss of expression of some important regulators of the inflammatory response, like the microRNA 145, 146, which are negative stimuli on TRAP6. And therefore, when losing this inhibition of TRAP6, there's an overexpression of TRAP6 and the NF-κ beta E. So this is associated to a greater production of alarmins, which feeds back this cycle. It is very important then that we know now the cytogenetic alteration generated by the modulation of the immune response, but it is also a syndrome where we know that the first-line treatment is an immunomodulating agent. Jorge will refer to this in his presentation. On the other hand, it is important that its overexpression is not exclusive of MDS. It might be seen in low-risk myelodysplastic syndromes. Regarding the alterations of the immune response in low-risk MDS, there's an overexpression of toll-like receptors, the ligands or the alarmins, and this determines inflammasome reaction, which ends up feeding back the inflammatory response, but also a particular cell death time, like the pyroptosis, and an expansion of the MDSCs, which will play an important role in feeding back this response and in generating suppressive cytokines and the overexpression of alarmins. So, what happens in high risk? In high risk MDS, there's a immunosuppressive response. It regulates the anti-tumoral immune response, which is given by a T anti-tumoral response, which will be downregulated. The T response will be T-regulated and it will be stimulated by the myeloid suppressing cells, but it will be an energia of the T cell and could be PD-1, PD-L1, and impress. So we know that in MDS there's an overexpression of PD-1 and PD-L1 in hematopoietic and in T lymphocytes, and it is important to block the anti-tumoral response. And in vitro, the blockade of this interaction is capable of restoring the hematopoiesis. So this PD-1, PD-L1 relationship is very important in generating this immunosuppressive reaction. Team 3, when interacting with its ligand galectin, this is seen in high-risk patients and secondary leukemia patients in hematopoietic stem cells, progenitors, and T-cell lymphocytes, like PD-1 and PD-L1. This expression is induced by TGF-beta, which is something which is worth mentioning here, and the overexpression is related with the proliferation of the progenitors and also with the progression of disease. So, now, what are the main characteristics of the alteration of immune responses seen in high-risk MDS? An overexpression of PD-1 or PD-L1, and the team 3 overexpression as well, and the expansion of the IL-T-reg signal, a blockade of the anti-tumoral mechanisms, and an expansion of myeloid suppressing cells, which was also present in low-risk MDS, which has to do with the phenotype. So the response of the innate immunity has a selective pressure that will stimulate the emergence and progression of the clonal hematopoiesis. There are mutations, specific mutations, like in some patients with MDS, like the DMNT3 and TT2, which, because of these effectors, immune effectors that will keep an altered immune response. And this keeps stimulating the proliferation and emergence of myelodysplastic syndromes. This innate activation favors more genetic and epigenetic changes that will perpetuate this process of disease. There are genetic alterations and cytogenetic alterations which are related to an altered immune response. We then have things that happen in the immature hematopoietic stem cell environment, which are, apart from the dysfunction, are translated into an altered response with more pyroptosis. And there's more alarming production There are also alterations like the deletion 5q, which is translated into an altered immune reaction, and the activation of the NF-kappa beta. There are alterations in the hematopoietic component translated into altered immune response. So we go back to the egg and the hen. What happens first? Which starts, which facilitates the whole thing? This is not so clear. What's clear is that the MDS is a disease of the tissue, and as such, there are stem cells that will act on the microenvironment, which will affect the microenvironment, editing and promoting a pro-inflammatory state. So this immune deregulation progresses then to an immunosuppressive environment which will allow the clonal proliferation and the progression to AML. This favors new genetic, epigenetic changes, and this pro-inflammatory stimulation will allow the emergence and progression of clones, and it gives rise to an acute leukemia. It is important to know this because knowing what happens in the immune response will allow us to identify targets. This is a pathology where we have a lot of knowledge, and there's like a mismatch to see how this could be translated into therapeutical options. There's a lot of progress that has been made, and this will help identify places to act upon. Thank you very much for the invitation. I hope that we can meet in person again, so thank you very much to you all. Thank you very much, Matilde, for this presentation of Microenvironment and Inflammasome. And the questions will be left at the end of the block. You can start asking questions through the chat box. Now we will move on. It is a pleasure to introduce Jorge Arbelbide from Argentina. He's a doctor, a hematologist. He's a professor of physiology of Hospital Italiano in Buenos Aires, hematology chair and director of a bone marrow transplantation program, a member of the Argentinian group of MDS and Glam. So, doctor, you have the floor to speak about the immunomodulatory treatment.
Good morning. My name is Jorge Arbide. I would like to thank the organizers of this symposium for their invitation to talk about immunomodulatory treatment in myelodysplastic syndromes. These are my disclosures. And today we will talk about the interaction between the immune system and the myelodysplastic syndromes. We will see the effect of the immune therapy on some specific conditions associated to MDS. We will go through the mechanism of action of the hypomethylating agents. We will evaluate the therapies with focus on the inflammasome and the combination therapies to boost the immune systems which are being developed at this point. Well, the immune system has a function to recognize what it's own to it and it's strange to it, and it has a role in the immunosurveillance against tumors. It is known mainly that the abnormal distribution of their cell populations related to the innate immune response and the specific immune response intervene in the progression of the MDS. That the pro-inflammatory activity mediated by the activation of the inflammasome leads to the death of the hematopoietic progenitors through pyroptosis, and that there's also a dysfunction, a deregulation in the immune system. We know that 10 to 30% of the patients might have these kind of manifestations, autoimmune manifestations at some point of the disease, which will require treatment with immunosuppressors. In the last decade, there has been a great deal of progress made in terms of the knowledge of the immune escape mechanism, especially for solid tumors. And today we will see how can we apply these treatments to the therapies of the MDSs. So the concept of immune dysfunction or deregulation leads mainly to the concept of autoimmunity, that dysfunction of the specific immune system generated because of the production of autoantibodies or the autoactivity of the T lymphocytes on their own structures. But we also have another concept, autoinflammation, which is the regulation of the innate immune system where there is a pro-inflammatory stimulation and consequent cellular damage. Even though we conceptually can separate these two alterations, in practice, both one as the other use the same activation and signaling pathways. Therefore, it is pretty difficult to separate them in the clinical practice. The immune response has a role in immunosurveillance and in the evolution and progressions of the MDSs. In the low-risk MDS, chronic inflammation favored by the generation of TAMPs and the activation of the inflammasome with the generation of pyoptosis and cytopenias, which is also favored by the genetic mutation. That all leads mainly to the proliferation of the malignant clone. In this chronic stimulation, will lead to the presentation of tumor escape proteins like PDL1 or CTL4. And in time, we will observe mainly in the high risk an increase in the regulator T cells, an exhaust immune response, and an increase in the myeloid-derived suppressor cells, which will favor the expansion of the tumoral clone. But not only the effects of the mutations and the immune response are reflected in the bone marrow, but the mutations that happen in the myelodysplasia clone will also affect and the effect and the functionality of the leukocytes. The mature cells interact with mutations like DNM, T3A, TEC, or JAK will generate an increase in the atherosclerosis risk, an increase in the risk of cardiovascular mortality, which actually are part of the conditions that generate mortalities associated to the comorbidities. Therefore, we have a systemic effect of these mutations. To start with immune therapy, I took three conditions, specific conditions associated to myelodysplasia, where there is a clear association with the immune system. One is the Epiplastic MDS, the other one is the 5q minus, and the other ones are the autoimmune manifestations associated to MDS. The hypoplastic MDS occurs in 50% of the patients and 10 to 15% of the patients, and this is an entity that is poorly defined in the classification of the WHO. In general lines, there is a overlap in the clinical and morphological manifestations between hypoplastic MDS and aplasia. They share the cytopenias, the hypoplastic module, and can have molecular cytogenic and dysplastic alterations. Classically, there are two types of hypoplastic MDS described. The one that seems more to a medullary aplasia, where there is cytotoxic activation, pro-inflammatory mechanisms which respond to immunosuppressive therapy, and those that look more to myodysplasia, in which there is an increase in the regulated T cells, there is more dysplasia, more survival, and a greater number of genetic alterations. We can see this in the columns to the right, in which in aplasia there are very few genetic alterations. One in the myoplastic case, there's more alterations, some with genetic and some with molecular alterations. The immunosuppressive therapy in these patients with hypoplastic myodysplasia has been effective, especially the combination therapy with thiomycete globulin and calcineurin inhibitors. Even though only 11% of the patients achieve full remission, achieving these levels prolongs the survival and increases the survival, the median survival, to 5 years. The patients that respond the most to this treatment with transfusion independence are those that have at least 20% of cellularity and have an scheme with ATG and cyclosporins. The other pathology that it's associated to a immune deregulation is the 5q minus syndrome, the deletion of the 5q31, q33 fragment generates the haploinsufficiency of the riboprotein S14, and this generates a blockage in the differentiation of the erythroid progeny, and then the death due to apoptosis due to abnormal functioning of p53. But this is not the only effect. There is also a decrease in the microARNs associated mainly to inflammation. When we look at the effect of lenalidomide, we see that this is a dual effect. On one hand, it has a direct activity on malignant cells, generating arrest in the cell cycle and apoptosis through the inhibition of CDC25C, or through the inhibition or the phosphatase and ubiquination and degradation of CK1 and IKZF1, but it also generates an increase in the proliferation of the natural killer cells and the cytotoxic effects on the malignant cells. And on the other hand, it decreases the pro-inflammatory cytokines and decreases the cytopenias, associated cytopenias. Despite it has immune mechanisms, the resistance mechanisms that happen in almost 50% of the patients after 2 years are more associated to genetic mutation mechanisms, such as the mutation of p53, which makes it lose that effect that the linolamide gave to the haploinsufficiency of the riboprotein S14, and the mutation of RUX1, which prevents the degradation of Icarus and casein kinase 1, and this generally induces to a maturative arrest in the megakaryocytic progenitors. And finally, the autoimmune manifestations associated to the myelodysplastic syndrome. This experience is that of the French group, in which they compare the patients that had not autoimmune manifestations. They didn't find differences by age or karyotype or IPSS. The survival in both populations was similar, and what they published was that from the patients that required corticoid treatment, 50% achieved a full or complete response, and the other 50% required treatment. And in a second work, they showed that the patients that were corticoid refractory or dependent, if they use azacitidine, the response to the hypomethylants was 91% after 6 months of treatment, and they achieved 73% of full remissions. These patients then could remove the use of corticoids or tap the doses, which speaks about the important effect of the hypomethylating agents on the immune regulation. We knew the action of the hypomethylating agents, and it was what allowed us to understand a little bit how the epigenetic regulation is, the effect on the CpG islands acting on the demethylation of the cytosine allowed for the re-expression of tumor suppressive genes, and this for some time was considered as the main mechanism of action. Later, we have seen that there are retroviral fragments that are silenced, incorporated into the figure and silenced, and when they hypomethylate, they express and generate a viral reaction with release of interferon, and this generates an activation of the immune response. And this is another mechanism that was recognized as an action of the hypomethylating agents, which is linked to the stimulation of the immune response. Dr. Constantini evaluated as well the hypomethylating agents response in intermediate and high risk MDS, and observed that there were some reductions in the T cells, regulated T cells, and there was a change in the expression of T cells, where there was an increase in the expression of FOXP3 and interleukin 17, producing the antitumoral T effectors. So, with this evidence in hand, we have to think that the treatment from now on for the dysplastic syndrome, in which one observe a lack of response, immune response in the progression of the disease. And the treatment with hypomethylating agents can be potentiated and maybe used acting at the level of inflammasome or acting at the level of the molecules that are used to evade the immune system response, like PD-L1, CTLA, TIM3, or CD47. We can look at the experience on medications that can block the inflammasome. As we said, the inflammasome is producing the activation with the protein S100 through the toll-like receptors. I could block the toll-like receptors and block the activation. If the inflammasome is activated, the NLRP3 is activated, and I could block it by using IRAC or TRAF blockers or inhibitors. We have also shown that BTK is an inhibitor of NLRP3, so we could use Ibrutinib. And if it has been activated, we could block the interleukins that are generated, like interleukin 1 beta or IL-18. Canakinumab is a drug that blocks IL-1B and has been shown to be efficient in autoinflammatory diseases. The experience with the toll-like receptors is not that broad. There are many protocols ongoing. The MD Anderson group submitted its experience with the tolamorelumab in therapy in patients low risk with refractory and hypomethylating. The objective was to achieve the transfusional independence, and on 50 patients treated, we achieved a response in 50 patients. Most of the responses were stable disease. Around 10% had a larger remission and 10% lower remission. We didn't observe great toxicity, and an activity, there was a moderated activity of this inhibitor. The other thing that we have published that also acts on the NLP3 is Ibrutinib. This is a work of combination with the Citabine 10 days in high-risk MDS and AML. Didn't show benefit with regards to complete response or with regards to global or overall survival. And there was no difference in terms of adverse effects. This work published recently confirms that, well, for this population of patients, adding Ibrutinib doesn't improve the therapeutical efficiency of the Citabine. Currently, there are several studies underway which block or act on the inflammasome, and we do not have results yet such as to be able to evaluate if this type of inhibition is going to have an impact in the treatment of the MDSs. The second groups of drugs that we can combine with the hypomethylating agents are the checkpoint inhibitors. The knowledge that there was expression of molecules that block the immune response, like PD-L1, no, or that was associated to tumor evasion. The blockage of these molecules was very important, obviously, because it allowed to reconstitute that tumoral response. It is a potentially interesting combination for the use with hypomethylating agents to see whether we can prolong the duration of the response. And the complication that it has is the development of immune adverse effects that we see in 20 to 40% of the patients. In these lines of treatments, the MD Anderson group was pretty active and published the use of nivolumab and ipilimumab with azacitidine in first line in patients with MDS, and also the use of checkpoint inhibitors in patients with refractory and hypomethylating. In the first line, there was a response of 60 to 70%. It was active in patients with mutations of RADS53. They recommend that we need to follow up the patient closely because there might be autoimmune manifestations that might require treatment with corticoids, but do not have results in the long term of how much will this therapy impact on the duration of the response. But in the phase with methylating agents, checkpoint inhibitors, they didn't have any effect, so they might not be useful for this work. The same group was continued going ahead and proposed a double blocking with nivolumab and ipilimumab in combination with azacitidine in first line and sinacitidine in relapsed or failed to hypomethylating agents. And even though in the first line the results as such are not much different to what you will get with a single inhibitor, patients with failure by achieving a survival of 11 months, which is much more prolonged than that obtained, for example, with other drugs. The rate of adverse events was acceptable, and they mentioned that this modality of treatment deserves having studies, population studies, such as to see what is really their impact. Currently, there are many studies that are evaluating the checkpoint inhibitors, and one of the considerations that most of authors make is that you need studies where you have a control group. Here, the study that combines azacitidine with ipilimumab clearly showed that there is no benefit in the first results in the combination of the checkpoint inhibitor with the azacitidine. But we still obviously need more results, such as to be able to evaluate whether this will have usefulness in a future. The other inhibitor that is being used is the antibody anti-CD47. CD47 is expressed by tumor cells and prevents the recognition of macrophage and their macrophagocytosis. The use of antibodies against anti-CD47 restore the phagocytosis of the macrophage, and the preliminary studies in combination with azacitidine the azacitidine gets rid of the phagocytosis and increase the response, restores it and increases the response. So the results in the combination with checkpoint inhibitor by Dr. Salman Elasco, magrolimab, but plus ASA showed a global response of 91% with 42% of complete response. The mean time was plus minus 2 months. The response is deep. It's active against P53, and it's more efficient, has low toxicity. But we do not have results in the long term, so we cannot yet say how much would this treatment impact. The other monoclonal is the monoclonal of TIM3 inhibitor. TIM3 inhibits the proliferation of the tumor T3 cells responding to tumors, and the use of the anti-TIM3 restores this and allows the immune tumor destruction. The work, the MGB453, combines this with the citabine or azacitidine, and it was done to evaluate the maximum tolerable dose and the recommended dose. They used 3 dose schemes: 240 milligrams every 15 days, for 4 to 500 every 15 days, and 800 in one single dose. The preliminary results show a remission rate, complete remission rate, with a combination with azacitidine of around 50% and with azacitidine around 40%. It has a good safety profile, but we do not have yet long-term results on how much would this response be maintained. There are several protocols that are actually combining these treatment lines, both with magrolimab and sabatolimab, even with intramosome inhibitors, venetoclax, as we can see here, as apart from azacitidine. So we are waiting for the results that can allow us to see or check what will be the impact towards the future. One last topic that is very important for me is that we are having newer and newer drugs all the time, but we need to have mainly biomarkers that can allow us not only to select the therapy and to be able to monitor the therapy. We've made a great deal of progress for the detection of mutations with the NGS, but obviously we will need to start doing other techniques, probably to measure the inflammatory profile, the autoimmune profile, so as to select the most adequate treatments for our patients. To wrap up, the immune system and the inflammatory response have a very important role in the development of the MDS. It is clear that there is a dysfunction of the immune system, and this we can see in different aspects, actually. the immune scape it's involved in the lack of response, and we need to identify it and establish strategic therapeutics adjusted to each patient, customized to each patient. The immunomodulator therapy acts at the level of inflammasome or potentiate the immune response, preventing escape through checkpoint, the anti-CD47 or sabatilumab in combination with hypomethylating agents has shown to be efficacy in a preliminary way, but we don't know the real impact in the long term. Even though we are having more drugs now available, it is necessary to improve or to try to identify biomarkers that might help us to decision making in terms of treatment and follow-up for our patients. And in that sense, I believe that the research work is critical, not only to evaluate the efficacy of the drugs, but also to identify these biomarkers that will allow us to increase the response rates in this MDSs. And finally, I would like to thank the group of hematology with which I work, to the subcommission of MDS, the Latin American groups of MDSs, and to all of you present here. Thank you very much, and I will be waiting for your questions. Thank you.
Hello again, and thank you very much, Jorge, for your presentation. We will now move to the Q&A session. Those of you who would like to ask questions, you can type your question in the chat box. There are some questions. Let's start with some questions for Matilde regarding the checkpoint molecules. What cell populations express this? Now we have a drug that inhibits this, and what's your response? Well, thank you very much, and thank you very much for the invitation. On the TIM3 expression, this is a co-inhibitory molecule which is expressed in many cells of the immune system, like T lymphocytes, particularly Tregs and TTH1, and this is expressed in other cell types like dendritic cells. And it's also expressed in hematopoietic stem cells within the context of pathological cells in AML. If these stem cells, which are normal, do not express TIM3, leukemia cells will. This is the first thing that we knew. And then in MDS, there was also an abnormal response of TIM3 in hematopoietic and pathological cells. Apart from TIM3, they express and overexpress the ligand of TIM3, galectin-9, which is also part of the co-inhibitory signal that happens at the T cells and dendritic cells and other cells. So there's a TIM3 interaction with its receptor, and we have an overexpression of TIM3 in T-regulating lymphocytes, like in acute leukemia, and an overexpression in the dysplastic pathological clone. Perfect. So then we will have like a double action. It works against the two cells. There's another question from Marcelo. Could there be a relationship between the Tregs expressed to define a transplant? As I said in the talk, these lymphocytes are very good in the immunosuppressing response, and they are expressed in high-risk MDS, and they are a marker of prediction to progression to AML. The expansion of the regulatory response will be more linked to patients with high-risk MDS, because there will be an immunosuppressive environment that will allow the proliferation and progression. Now, regarding the treatment with hypomethylating agents, there are in vitro experiences that are associated to a modification in the number of T-regulating cells. And this treatment is capable of reducing this population in responding patients. This could be a predictor of response. Now, we see that patients present a decrease of NK at the beginning, at the onset of disease, and then it's like a restoration once they start responding to the treatment. This is evidence in vitro and then in vivo. We saw that evaluation, the function of NK in patients with hypomethylation agents was a predictor of response. For cytidine and others, there's in vitro for decitabine. Well, thank you very much. And there's another question, I don't know, it could be for both. What innate studies are useful in practice? The toll-like receptors, or what would be the most important marker of pyroptosis, and if it's useful in the practice? There's different progress. There's a lot of studies that are being used to extend immunity. Maybe one of the most interesting techniques is mass cytometry. Mass cytometry is a different technique which helps us evaluate populations which are immune, and not only the protein expression could be something that will assess cytokines. This is a technique which is being seen as something good to have a real appreciation as to how the immune response is in these MDS syndromes. Of course, if, as I said, or Elvira said, we are trying to be able to afford these techniques, they will take long. And what we are doing in our daily practice is immunohistochemistry for PD-1, the ligand. We have immunohistochemistry techniques, and we cannot assess otherwise right now. The other aspect that I think is actually very important in this question is how can we assess pyroptosis? There are proteins which are the proteins that are produced or released throughout pyroptosis. Those proteins can be measured. These proteins will be released towards the extracellular medium with a pro-inflammatory technique that will trigger the caspase effect with subsequent interleukin-1 beta generation. So the inflammatory response will continue. There are techniques being developed, and of course there are others out there. Maybe Matilde can mention about some, but they are being implemented so that we will have a way to assess the immune response in myelodysplastic cells. And there's a question that follows this same question, if there's a way to evaluate NLRP3, and if the response could be predicted. And what could be more effective to measure? Is it low or high risk patients? Regarding this, Jorge has been mentioning the options that we have to measure the activity of the inflammasome indirectly. There are other indirect ways, like plasmatic dosing of the alarmin side ligands of the toll-like receptors, and this could be made with very simple techniques. Could be closer, maybe, and to directly assess these is not something that we can do clinically speaking. Is within a research context, or maybe in the future to study the genic expression through NGS by way of the RNA-seq with a global assessment of the inflammatory inflammasome, so to speak, the immunobiome, to study the response in a patient. Well, I think that this is something that's farther away from the clinical presentation. Maybe it could be on clinical trials where we are testing the effect and then taken to the clinical experience. Maybe it's low risk first, and I think that these will be prone to measuring the immune response. Well, now, like moving to treatment, there are similar questions, so I will summarize them. What is the role in the use of corticoids in MDS related to all of the things that we have discussed so far? Yes, regarding corticoids, corticosteroids, the first thing here is to see what to treat with corticosteroids. They play a role in autoimmune manifestations. The corticosteroids, first line of treatment for this type of disorders, and if it fails, we can use a second line with hypomethylating agents or immunosuppressors. As treatment for the disease to block the inflammatory system, this is something that won't have benefit and won't be sustained with time. So I think that no. The answer would be no. And fundamentally, I don't think that we have much to do with corticosteroids here in terms of the operational profile. And therefore, well, they are asking about your opinion to see what MDS risk group will be mainly affected with this hypomethylating combination with checkpoint inhibitors or anti-TIM3 or L1B. What are the challenges with these new therapies? Yes, the truth is that these therapies, as I showed, are under research now. When you take a look at your preliminary work, what you normally do in a big part of phase 1 trials is to use the association with a hypomethylating agent without a control group. This generates a problem because when I see that there's some benefit, there's a comparison with the historic group, but not with the population that would have been randomized with the same characteristics. And sometimes, as we saw, there were many therapies, combination therapies that we have with hypomethylating agents, which were favorable at the beginning, maybe the histones at the beginning, and when they were compared with other groups, they didn't have a true impact. So I think that yet the checkpoint inhibitors, if they show some outcomes, positive outcomes, this is quite limited. The work with control groups with azacitidine and dormilumab has not shown benefit in the first cuts of the study. Now, regarding the TIM3 inhibitor, these are therapies which are more interesting, meaning that there the preliminary work has no control group so far, but the others have, so we will know what's the impact, the true impact, but the response rate and the full remission and recovery rate is very high. It's much higher than that obtained with the hypomethylating alone. It's much faster. It seems it's deeper, but if you ask me when will I use a TIM3 inhibitor or a antibody with the other one, it seems that there's lacking information. We need to have markers that will evaluate the proteins that we have to see how we might combine drugs. This is why I mentioned during my talk that it is good to have new protocols with new targets. We have to have biomarkers that will allow us to define when is it more advisable to use the combination vis-a-vis other situations. I think that we're still lagging a little bit behind. We need more experience This is why I mentioned that the works and protocols need to have not only the combinations, but also the biomarkers that will help us detect which could be the best candidates for each line of treatment. And maybe there are combined strategies in the future. Well, regarding Jorge's response, in Team 3, there's a possibility of evaluating the flow cytometry expression, and this could be something that would help in selecting patients that will benefit from a combination therapy. Those that are showing overexpression of PD-1, PD-L1, yes, it's markers that could evaluate the expression. This is one way of quickly diagnosing to then select possible candidates. Well, the truth is that we are running out of time. We still have some questions from the audience. We apologize if we could not answer your questions. Thank you very much for the interest. We've been filled with questions in this talk because these are new issues, and we will hope we have some outcomes soon. Thank you very much to you all, and then we will resume at 2 p.m. Uruguay time to continue with our meeting. Thank you very much, Sofía, Matilde, and greetings to all of you. Thank you very much to all of you.